Hello, thank you for joining me. My name is Anil Taylor. I'm a consultant gynecologist and I practice in the UK. In this video, I want to talk about what considerations we give to fertility preservation when we are treating somebody with a newly diagnosed cervical cancer. If you remember, cervical cancer often affects women in the reproductive age, and so many women are caught out not having completed their family and are diagnosed with a cervical cancer and having the dilemma of what is their priority. So I have previously uploaded a comprehensive video, a three-part video on how we investigate cervical cancer and how we use the information from all the scans to decide what the best form of treatment for that individual would be. And so please search those videos out because they will help you understand what I say in this video. Now, let us assume that the cervical cancer is early, because if it is late, then clearly all that we would be able to do is give you palliative treatment, and therefore there may not be that much consideration given to fertility preservation because there won't be time. But let us assume that your cancer is early or early stage, and that therefore you are going to be treated with curative intent. Now, the curative intent can be delivered either by surgery or by chemotherapy, and all this has been discussed in a previous video. So as a rule of thumb, the early stage tumors are treated with surgery, but the more advanced tumors are treated with chemoradiotherapy. So it's really when we are dealing with an early stage cancer where we are treating with surgery where we can potentially apply fertility sparing options. So essentially what that means is that if the cancer is so early, meaning still in the microscopic phase, then sometimes we can treat it just with a cone biopsy, where we just take a cone of tissue from the cervix, and that more or less preserves your womb and quite a bit of your cervix, and allows you to fall pregnant by yourself. Of course, there can be consequences in future pregnancies, like premature labor and all these sort of things, or miscarriages, but that's for a different video. But a cone biopsy in very early cervical cancer could be an option that would preserve your ability to fall pregnant by yourself. There is another operation called a trachelectomy, which involves taking out that amount of tissue, where we just take out the cervix, leave the top of the womb behind, take out a little bit of the vagina, and then in that situation, we have to put a suture in. So we also stitch the bottom of the womb back to the top of the vagina and leave a permanent suture in. Any future pregnancies would usually be delivered by cesarean section. So here, in this situation, it preserves your ability to fall pregnant by yourself with your own genetic material, because your ovaries are still there. So these are the two main fertility sparing options that are available when somebody is diagnosed with cervical cancer. Now, even with the trachelectomy, that operation is not suitable for all patients with early cervical cancer being treated with surgery, because there are some cancers that are fairly large or chunky or have microscopic features that may not be the best or safe to be treated with a trachelectomy. So under those circumstances, we would essentially recommend a sort of an old-fashioned radical hysterectomy. So those criteria may differ from hospital to hospital or clinician to clinician. So obviously you would need to listen to what your specialist tells you. Now, if you are having a hysterectomy because, say, a trachelectomy is not an option. So a hysterectomy is where we would remove the whole womb and the cervix. Now, often that would be a radical hysterectomy, but that's besides for the time being. If the womb is removed, then your ability to fall pregnant yourself is obviously destroyed. Now, of course, you still have your ovaries, so you still have your eggs, and they could in the future be, once you've been fully treated and been cured, eggs from the ovaries could be harvested, and you could then have a surrogate to hold a pregnancy for you. So that is possible if you retain your ovaries. Now, most cervical cancers, we are able to retain the ovaries, but there are some exceptions. But in most cases, we are able to. Now, if the cancer is more advanced and you're going to be treated with chemoradiotherapy, then there are not many fertility sparing options here, because if you consider the fact that the uterus and cervix are roughly in that position, and the ovaries are in that position, and the colored areas is where the radiotherapy is concentrated. So whenever the womb receives this kind of intense radiotherapy, it usually destroys the ability of the womb to hold a pregnancy. So the uterus, even though you still have a uterus, it becomes a hostile environment, and you're not able to retain a pregnancy, or indeed even develop a pregnancy. Of course, there are rare exceptions that have occurred, but on the whole, once you've had radiotherapy to the pelvis for cervical cancer, then you should consider yourself potentially infertile. Now, of course, remember that if the ovaries have been left in the pelvis, then when you receive the radiotherapy, of course, all the eggs within the ovaries will be destroyed, and your ability to even fall pregnant or retain your own genetic material to be able to then get a surrogate to fall pregnant for you, even that is then destroyed. Now, there are ways that we can alleviate that. So if somebody is having radical chemoradiotherapy, we can consider something called egg harvest, whereby prior to starting your treatment with chemoradiotherapy, we make an urgent referral to an infertility specialist, who then considers stimulating your ovaries and with some hormones, and then taking some eggs from those ovaries for storage. And then once that has been done, which can often be achieved within 3 to 4 weeks, once that has been done, then you can start your treatment for the cervical cancer. Now, egg harvest is a complex topic in itself, and I will cover that in a different video. But as a rule of thumb, storing eggs is a bit more problematic than storing embryos. So the difference is that if you already have a partner, and then the eggs can be mixed with sperm, and that can obviously then create embryos, and it is easier or more successful to store embryos rather than to store eggs. But research is still being done to make advances in that area, so perhaps in the near future they will be just as successful in storing eggs as well. So that's one way whereby you can retain your genetic material to get a surrogate to then hold a pregnancy for you. The other thing that we sometimes do is if somebody is going to be having radical chemoradiotherapy, we can do something called ovarian transposition. So if you remember, somebody's ovaries are usually in that position in the pelvis, and we can separate those ovaries and the blood supply to the ovary and take them all the way and put them high up in the abdomen. And so they are then not within the radiotherapy field, so they are relatively protected, but this operation doesn't always work, and I will cover this in a different video. Now, they are high enough to be, as you can see, just very close to the liver and spleen. There are many centers where they don't put them as high as that, and they would put them with those ovaries relatively low, but they can achieve similar degrees of success. We do, in our centers, we do our operations with robotic surgery, and we are able to put the ovaries very high up. So that essentially is ovarian transposition. That is all I want to say about options to preserve fertility in somebody with cervical cancer that is about to be treated. Of course, please watch this video in conjunction with the other 3-part video that I have uploaded to put everything into context. So that is all I'm going to say. Thank you very much for joining me, and if you find these videos helpful, then please consider subscribing or clicking the like button. And until next time, see you in the next video.